All yours.
Right. Hello, everybody, and thank you for tuning back in this time. And sorry about any technical glitches last time, but I think we've got those all ironed out. I don't know if all of you were at the presentation that I gave on January 8th. I know some of you were. And what I was talking about then was the topic of the progress we've made and where we are in the general area of health promotion and disability prevention with older people. And what I wanted to do today was just to focus in on some of the issues that I talked about then, but within the context of residential care, because as I said in my presentation, I think our efforts at health promotion and disability prevention really sort of fall off a cliff in many cases when we're talking about people in residential care and people at more advanced stages of frailty. So I'd just like to get some discussion going today around some of these issues, specifically around residential care. And there are just a few areas that I thought we'd concentrate on. And you see those listed here on my slide, talking about some of the organizational or institutional barriers to health promotion and disability prevention within care home settings, describing some of the evidence that's emerging around health promotion outcomes in relation to so-called culture change interventions in residential care, and then finally getting some discussion going about the feasibility of achieving the aims that NICE has set out, the National Institute for Health and Care Excellence guidance has set out in terms of health promotion and disability prevention with older people in care homes. I'd just like to start out by asking you to just type a bit in the chat room about your experience, if any, in care homes and nursing homes, whether that be personal experience with a relative or direct work experience. And I'll also say a bit about what my experience has been. So if you'll just type something in the chat room, just telling us a little about what your experience has been. And I'll do the same. right? So we see a sort of range of what you all are telling us. Somebody said that they don't have personal experience, but is receiving patients from, I'm assuming that's residential homes, care homes, and Josie's had experience with a placement with district nurses. I'm sorry, I don't know what the first name is of the person who's responding under Josie, so sorry I can't call you by your name, but this person's saying that they've had limited exposure, aware of the bad press that we see about care homes. And Ray's telling us he's been trying to develop the use of Skype for people in care homes. And so has been visiting various care homes around Plymouth. My experience in care homes has been primarily in terms of conducting research in care homes, both in the U.S. and now in several care homes in Torbay. In the U.S., I did a study around the use of restraints. This is probably about 20 years ago in a very large care home, looking at the kinds of organizational factors, including staffing and the culture of that care home that facilitated or reduced the use of restraints. There had been national legislation that had been passed saying that people in care homes couldn't be restrained unless this was documented, that there was a good reason for this. It was extensively documented in the residents' charts, and that there was monitoring of the use of restraints, which previously had not been the case. So we looked at the effect of this new law on the reduction of restraint use and found that there were, as I said, organizational factors that were related to whether or not this law was actually carried out in this particular context. So again, staff's ability to comply with the law was affected by things like adequate staffing levels, attitudes of the management, and the culture of the home around implementing this in a proactive way. And then currently I'm carrying out a study in Torbay, which is looking at the use of the training of dementia champions in homes with residents with dementia, and actually getting greater awareness of dementia and good practice around dementia into care in these particular homes. Bethan's saying that she's had some experience during nurse training, as well as several months in a care home, and some experience in an elderly mentally infirm unit as part of a mental health placement. But also personal experience of visiting grandparents who are in a home. And just reading down through people's responses, it doesn't seem to have been much of a positive experience. There are some questions, Ray, about about teaching people how to Skype in care homes. Maybe you can reply to that. I don't know if Ray's still typing, but anyhow, we've got a range of, Ray's replied. So he's telling us that it's still early days with trying to implement his Skype on wheels concept. And he's trying it out in various care homes. So just moving on, trying to get the next slide here. Moving on to the next slide. This is for those of you who saw my presentation in January. This is a slide I had put up then, which organizes what we know in terms of the evidence about factors that have been identified as so-called keys to successful aging. And successful aging here is defined as high-level functioning and is distinguished from so-called normal aging. And these three keys, just to recap, are avoiding disease and disability, maintaining high cognitive and physical function, and also maintaining high levels of social engagement. And that's an area that I want to emphasize as well, because we do traditionally see more about avoiding disease and disability and maintaining physical functioning especially, but maintaining high cognitive function and maintaining high levels of social engagement are things that I want to emphasize, particularly around the care home setting. Now, what I'd like to get a little discussion going around here is on what you think some of the implications are in terms of the evidence that I presented in my talk back in January on areas like loneliness, the impact of loneliness, which has been shown to have a similar effect to a similar impact on health and risk of disability as one recent study found in terms of smoking 15 cigarettes a day, and also on the evidence I presented around the positive effects of physical exercise, both on cognitive function and on physical function. So some of the evidence that we're seeing that there is a massive reduction in risk in terms of the development of dementia related to maintaining high levels of physical exercise, and also on the levels of physical function that can be preserved through maintaining regular exercise. So can we say something about what the implications of that evidence are in terms of the care that's provided in residential homes and in nursing homes? What would you say, that about whether or not we can institute these kinds of measures in care homes? Do you think that's achievable? Any views on that? Clarifying the question. Okay. I think I was trying to recap some of what I presented in my talk earlier in January, which really looked at what we know is possible in terms of maintaining high levels of cognitive and physical functioning in older people. And what I was interested in getting your views on are what you think are the implications of some of that evidence for care in residential homes. Right. Ray's replied that he thinks it's much easier to assess whether or not physical health is maintained. I'm trying to look at the end of, and that this will get priority, but that assessing loneliness is more difficult. I'm going to talk about how within the so-called culture change interventions in care homes, that loneliness has really been a target of some of these activities. So yes, physical health may be easier, but there's a great move now to target other aspects of people's subjective well-being, including loneliness, helplessness, for example, and other psychological outcomes. Josie says that the evidence is there, but the resources aren't there, and so unless volunteers in these homes are educated in using using this evidence, she's not sure how achievable implementing any of these recommendations are going to be, and that really gets on to my next question, which is what do you think some of the main barriers are in promoting older people's well-being in care homes? And in particular, I'm interested in mental well-being, because I put some nice guidelines up on the portal, and some of you may have had a chance to look at that, but they're focused on mental well-being, so areas like life satisfaction, optimism, self-esteem, feeling that you have control, a purpose in life, that you belong that you belong, and that you're supported. So my question is, within care homes today, what would you say are some of the main barriers to promoting residents' well-being as it's defined here? Mental well-being in particular. I'll just add some of my own thoughts about it. Right. There seems to be agreement that staffing is just a key factor. The need for care assistance with training, so knowledge about the residents in the home. The enthusiasm that carers have for their job is something that Josie mentioned, and certainly, for example, and Zoe mentions perhaps some staff being young and of different backgrounds or cultures than the residents. And just to use the example of the study that I mentioned about the use of restraints on residents in a care home in the U.S. that I did a number of years ago, these were all factors that we showed to be relevant to achieving mental well-being and also restraint-free care for the residents of this home. Adequate staffing levels or inadequate staffing levels were probably the biggest factor. Staff really weren't keen about using restraints. This was in a dementia unit, and again, just to remember, this is about 20 years ago, where when the use of restraints was much more commonplace than it is today. But staff said, we don't want to do this, we don't like doing this, but if you are responsible for, say, 60 residents, a good proportion of whom are at risk for falls. They felt that there was just so much that they could do to allow residents to have autonomy and also to ambulate freely throughout the care home without actually putting people at risk for falls. So they said they wanted to do much more around psychosocial care and individualized care for residents, but they considered it not possible and a barrier to providing good quality care. And this demoralized. This really demoralized staff too. So lack of enthusiasm, which is one of the factors, one of the factors that was mentioned in your comments was something that really affected patient outcomes in that particular study. Bethan mentions that it's not considered a glamorous area of nursing. I think because of many of the factors that you've mentioned here, and the fact that within some care home settings, there's little latitude for improvement in the way work and care are carried out at present because of some of these organizational factors that staff are demoralized and that it's not considered a very glamorous area of care. Task-oriented nursing, which is what social scientists like me call, or the literature refers to as bed and body work, and which predominates a lot of care, very instrumental oriented care, as opposed to being able to look at the more expressive side of things. There was a study a couple years ago that looked at the amount of time that care assistants spend talking to care home residents with dementia and the nature of that conversation. It was something appalling, like, I can't remember, I think it was something like 10 minutes a day, and it was all, and much of it was around instructions for what the care assistant wanted the resident to do, like put your arm in this sleeve, sit down, and so forth, because there was very little time, and also within that particular environment, diminished inclination for having longer chats with these residents. Low pay, another factor. And so I think in your comments you've pretty much hit all the major suspects in terms of organizational factors that conspire to make care in many homes less than it could be, and that the prospects for really fully implementing guidelines or realizing aims around health promotion and disability prevention and around people's mental well-being, as it's defined here, less than it could be. Right. Just moving on to a bit of a more positive picture. I don't know how many of you are familiar with the so-called culture change movement in residential care. This particular term comes from the U.S. and it is perhaps more referred to in the UK as person-centered care or person-directed care, and you may be familiar with it if you know about the My Home Life program, which is looking at initiatives in person-centered or person-directed care in care homes in the UK. You can read more about the culture change movement at the website address that I've put up here. But in the U.S. and more generally, culture change in residential care refers to a kind of grassroots movement that was started in the early 1990s by ordinary citizens, so older people, their family members, care providers, and advocates. And the aim was, their aim was improving quality of life in residential care. The movement itself is grounded in the belief that you can introduce all the kind of legislated care standards that you want, or quality improvement systems, or focused therapeutic programs like horticultural therapy, or pet therapy, or music therapy, but none of those things essentially alter the care home culture. And they go on to say that real and enduring change can only occur from a fundamental shift in the whole underlying paradigm of care that presently exists. So a shift from a medicalized, essentially medicalized, vertical system where you have, care home owners at the top, managers underneath them, professional staff under them, care home assistants under them, and essentially residents at the bottom of the heap. And also this model is very technocentric, much less focused on psychosocial aspects of care. So advocates for care home culture change says that all of that needs a kind of fundamental shift or reordering if you're going to have lasting change in quality of life for care home residents, and also make homes places that are fit to be called homes, and also places that people who work in these facilities are satisfied with in terms of places they want to work, are enthused about working, and where they feel that their work actually makes a difference to the quality of life of residents. I want to go on and just give you an example of one of the models or so-called approaches to culture change in residential care, and that's the Eden alternative. The Eden alternative has been around again since about the mid-1990s. It's been operating in the UK since 2005, and if you go to the website address that's listed here, you could read much more about homes in the UK and also in Europe that have adopted this approach. All in the United States, all 50 states have Eden alternative projects running. Homes can be accredited as being Eden alternative certified. Homes in there are a growing number of homes in Europe, in Denmark, for example, have adopted this approach, as well as in Asia and in Australia, and in a growing number of countries. And essentially, there are three fundamental aspects to this particular culture change model. and they involve changes to the physical environment, to staffing, and to involving residents, so increasing resident autonomy. So in terms of the physical environment, for example, creating a thriving home-like environment. So the Eden Alternative Model doesn't prescribe what kinds of changes a home carries out. It feels this approach says that each home knows best what it can do in terms of facilitating quality of life for residents, but in terms of the physical environment, changes would include things like making meal times a more pleasant experience. So dining rooms actually resemble places in people's homes rather than being sterile or clinical, and doing things like putting tablecloths on tables, and any other changes to the physical environment, having plants, for example. Some homes even allow pets within the home, things that humanize the physical environment and make it more home-like. In terms of staffing, typical changes are meant to empower staff so that they have more latitude in terms of decision-making at all levels of decisions that happen in the home, and that their roles are more flexible, and that they care for smaller numbers of residents, which allow them to take to spend more time with residents. And then finally, in terms of resident autonomy, the kinds of changes that homes typically adopt under the Eden Alternative allow for more residents' greater involvement in determining the nature and routines of the home's life. So residents, to the extent that they are capable, get to have a say in how routines are carried out and within the home. So for example, if people don't want to go to bed at 7 in the evening, want to stay up longer, and just as an example, there's flexibility that's instituted within the home to allow these things to happen. So anyhow, could I get you to say something about your understanding of person-centered care, and if any of you are familiar with any of these initiatives in terms of implementing culture change in residential care in the UK, or if you've, say, come across these kinds of models in relation to care in other countries. Can I repeat the question? Sure. Zoe's asking if I can repeat the question. Can you just let us know if you're familiar with any kind of approaches to to culture change in care homes that you've come across in the UK? Or if you've read about any of this happening elsewhere, right? Josie says she's not familiar with the initiatives. They sound like a great idea. Zoe says she hasn't come across these yet. Anybody else? I see Ray's nipped off as well. Right, so right, and if you're not familiar with any of these particular approaches per se, if you look on, interestingly, if you look on the websites for any care home, you will see that person-centered care and a lot of the things I'm talking about are really very prominently displayed on the websites of care homes. So from a more cynical point of view, care homes are very aware of using using the idea that they're promoting person-centered care as part of their marketing for their care home. So you'll see that within the care home industry that there's a fairly high level of awareness that this is the kind of care that relatives are looking for, that residents are looking for, and Zoe's right, CQC are more involved as well. Right. Now, in the U.S., just to give you an example, because I'm much more familiar with what's being done in terms of culture change in care homes there. This is still very much on a voluntary basis as well as here. But in the U.S., for example, people promoting these different models are now working with statutory agencies around things like regulations for hygiene. So, for example, around the issue of the introduction of pets into care homes. Now, that might be some residents may feel that that's a really good idea, but how does that square with rules on hygiene in homes? And so around many of these issues, that could be a problem, and that if you strictly go by the book in terms of regulations and health and safety laws, wouldn't allow for some of the changes that are proposed in terms of culture change. People in this movement are, as I said, working more closely with some of the statutory agencies to see what kinds of creative solutions that they can come up with to enable some of these changes. And so it forces both regulators, or it helps regulators and those who want this kind of change in care to creatively come up with ideas for enabling these things to happen. Josie says she loves the idea of pets, a private care home It says where she used to live, had a dog, and the residents loved it. That's right. Right. So these things are happening in care. As I said, a program called My Home Life is being more widely adopted in the UK, but the Eden alternative is up and running and has been for a number of years. And what I wanted to show you next is some of the evidence. I've just put a few bulleted points here from some of the studies that have been done around the Eden alternative. There was a so-called case control study, which is a very rigorous scientific design that compared outcomes for a number of homes that had adopted the Eden alternative with a number of matched homes whose residents were just as frail, who had similar staffing levels and were very similar in size and a number of other factors with the homes that had adopted the Eden alternative. And there were some quite stunning results that came out of this particular study, which was quoted a lot, and I've just listed some of them here. There were highly significant improvements that were shown for the so-called Edenized homes, those that adopted this approach, in terms of things that you would expect. Staff absenteeism. People were much more enthusiastic about working in these homes because they had a greater role to play. They felt like their views on care were taken on board. There was much more flexibility in their roles. And so staff absenteeism went down by 48% across the homes that had adopted the Eden alternative. There was also greater, I don't think I've listed it here, but greater job satisfaction among staff and far less staff turnover in these homes. In terms of resident outcomes, and again, I've just listed a few of them here, there was a 57% decrease in new pressure sores in the Eden alternative homes compared to the control homes. There was a decrease of 25% in terms of bedfast residents, and we can speculate about what in these changes had actually caused these kind of huge clinical changes. And another one, which I haven't listed there, was a significant reduction in respiratory infections in residents in the Edenized homes. Now, the kind of mechanisms that would be involved in that would be interesting to speculate on. And, you know, I'm sure further research or studies would actually look at the immunological status of residents in these homes. There was a 60% decrease in behavioral incidents in these homes, which is a kind of change that we could imagine if there's more time being spent with residents one-to-one, if people felt that routines were more adapted to their personal preferences, and they felt cared for and listened to, that there would be fewer behavioral incidents, and in fact there were. Another study showed, in 2001, showed that there was improved functional status among those in Eden alternative homes compared to control homes. Other studies have shown, for example, that families were more satisfied with care received in the Eden homes than in control homes. And then going back to what we were talking about earlier in terms of the mental well-being of residents, boredom and helplessness were shown to be significantly decreased in Eden alternative homes compared to controls. So along a whole host of different parameters, resident outcomes, staff outcomes, family outcomes in terms of satisfaction, and also facility level outcomes, which I haven't shown here, all show significant improvements. So Ray is asking, Ray's asking about pets. What if people don't like pets? This is all negotiated. These changes are negotiated among residents. So, for example, in one home, Ray, I know that for people who had dogs that they wanted to bring with them into the home, there were pet doors put into the person's room, so that the pet could go outside into an enclosed area, but could come back into the resident's room. And if other residents didn't like having the pets around, that they wouldn't be roaming freely in the home. So I'm just trying to, I'm looking at other comments here. Exactly, as Josie's saying, all residents were asked first, and she seems to be indicating that the residents became more active, and that there was more social involvement because of having the pet at the home. So again, in a lot of these homes, the idea is to literally sort of bring the walls down that exist between the facility, the home, and the outside community. So a lot more intergenerational involvement with students visiting the home, for example, and other community groups. And I think your comments reflect what some of these changes could be. So just since we've just got about 6 minutes left, going back to my kind of original point and the issue that I wanted to focus on, which is health promotion and disability prevention within the care home environment. What are your views about how some of these proposed changes, or these changes that are actually happening in some care homes today, would have on the health status, and particularly on the mental well-being of residents, and also on how staff would feel about their work in care homes. Good. Hi, Rachel. Rachel says that a friend of hers from nurse training runs a home now and is very involved in dementia awareness. And feels that it would certainly improve quality of life, also improve the work for nurses too. And Josie feels that it all sounds very positive, both for residents and staff. And the evidence seems to bear this out. Just in terms of something that some of these studies have shown, and I'd be interested to get your comments on this, among different kinds of staff in care homes, nurses oftentimes found some of the changes in terms of role to be, they found it more difficult to accept than, say, therapists or people from other professional backgrounds. And it seemed to be that nurses had a fairly clear view of what they thought the nursing role was, and perhaps felt that it was a bit difficult to adjust to possibly doing other things that they didn't see as within the nursing role. Any comments about that? Josie's got an interesting comment. She says that her take on that was that possibly that because nurses are there constantly and other care workers like therapists come in and out, there may be more of an initial resistance to change with the nursing staff as they'll notice it the most. That's an interesting take on it. Another comment that nursing roles change every day, and embracing that change for the benefit of the patient is vital, but perhaps it needs to be more manager-driven, and that's absolutely right. These culture change initiatives all put quite an emphasis on management, the change that needs to happen with management, and so they can react to and support what's happening with care staff. And as Rachel says, taking care of the whole person is what it's all about. So that the whole team needs to work together to achieve this. And again, the comment that care change needs to be well delivered and led. Right. As I mentioned, I'm working with a project in Torbay at the moment, which is training a member of staff in each one of the participating homes to be a dementia champion, and also providing training on dementia for other staff in the home. But this is supported and led by the dementia champion and management of the home, and in a kind of program of continuous support, which networks the staff across the homes. Okay, I think we're just about at time here. Ray says he needs to close the webinar in a minute, but thank you all very much for participating and for your comments today, and I'll be putting up additional information on the portal on culture change in residential care, and also for the second webinar on so-called dementia-friendly communities, which is another topic that we'll be talking about. So thank you again very much for participating today, and I guess we're all logging out.
Yeah, I'm going to close. I'm back on the microphone, so I'm going to close the webinar now. Everybody can stay in the chat room if you want to stay there, of course. Bye.
Thank you, Ray.